Afternoon, and thank you for joining us today for this briefing. My name is Fadich, and I am the Vice President of Men's Health Network. Today, we are here partnering with the Foundation for Breast and Prostate Health in collaboration with the Congressional Men's Health Caucus and Prostate Cancer Task Force to bring you this briefing on prostate cancer screening and the U.S. Preventative Services Task Force challenges. I want to start off by thanking the congressional members of the Congressional Men's Health Caucus for their support in this briefing and for the many events that we've done on the Hill over the past few years. Our co-chairs hopefully will be able to join us today. Congressman Markwayne Mullin of Oklahoma's 2nd Congressional District and Congressman Payne Jr. of New Jersey's 10th Congressional District. We want to recognize them for their leadership and support over these years because they and their offices have been wonderful partners of ours. I don't see, we do have the great pleasure of having Congresswoman Marsha Blackburn here. Is she here? She's not here yet? Okay, great. Well, when she does, we will introduce her. I also want to thank the staff of Men's Health Network for making this event possible today. Brandon Leonard, Kendra Anderson, Kim Pringle, and Joshua Garner. We want to thank you guys for that. We have a wonderful lineup of speakers today, but I wanted to quickly go over what is in each of your folders. So inside, you will find the presentations of the panelists and their bios. Included also are the bills, which we'll be discussing today, and informational background around prostate cancer screening and the task force. And finally, there's information on the Congressional Men's Health Caucus. So that you who are working on the Hill can go back to your bosses, and if you're interested, please contact Taylor Gilliam of Congressman Payne Jr.'s office, Taylor Gilliam of Congressman Mullin's office, and Tom Saunders of Congressman Payne Jr.'s office for more information. We'd love to have more members join us. We currently have between 35 to 40 members. All right, so let's begin with this. Our first speaker today is Dr. Deepak Kapoor. Dr. Kapoor is the chairman and CEO of Integrated Medical Professionals and president of Advanced Urology Centers of New York. His medical background is diverse with both laboratory and clinical experience, both in academic and private sectors. Dr. Kapoor's expertise includes basic science research in molecular biology, as well as extensive experience in oncological and reconstructive surgery. Under Dr. Kapoor's leadership, the Integrated Medical Professionals have become the largest comprehensive urology group practice in the U.S. He has published and lectures extensively on both clinical and medical issues and serves on a number of medical advisory boards. Dr. Kapoor?
Thank you. Good afternoon, everybody, and thank you for the kind introduction, and thank you for taking a few minutes to have me speak to you about this important subject. As mentioned, I am representing both an academic as well as a private sector group. I'm on the academic faculty at Mount Sinai in New York, as well as we run Integrated Medical Professional, which is the largest urology practice in the United States. Our group does about 1.5% of all the urology volume. We have about 100 physicians in 55 offices throughout the New York metropolitan area. So to give you a little bit of a background, as an overview, PSA-based prostate cancer screening has greatly altered the way that we diagnose and that we treat prostate cancer. The USPSTF, through a flawed and non-transparent process, issued a one-size-fits-all grade D recommendation that recommended, believe it or not, that no one should get a PSA done. No asymptomatic man should get a PSA done. What you're going to see from the data that I'm going to show you, and I think Dr. Ginzburg will support, is that we're seeing fewer diagnoses of cancer and an increase in the incidence of higher grade, less treatable disease. The USPSTF Transparency and Accountability Act will reform the process to ensure that the American public continues to get access to vital life-saving screening services. So let's start by looking at what happened with PSA-based screening. But PSA is something known as a serine protease. It's something that's produced in prostate tissue, and it's exclusive. It's not cancer specific, but it is prostate specific. It does exist in very low level in other organs, but for the purpose of our discussion, it's prostate specific. And we can see, excuse me, prior to 1986, when PSA was introduced, the death rate from prostate cancer was relatively flat. From that point in time, we can see that the death rate from prostate cancer declined from 39.3 per 100,000 down to, in 2012, 19.6 per 100,000. Excuse me. Which is a decline of about 50% over that period of time. Furthermore, what we're also seeing is that prior to PSA-based screening, the death rate from prostate cancer, in other words, the number of people that were dying specifically of prostate cancer, went down from 53% of men diagnosed. Now the 10-year survival is up to 99%, which is absolutely extraordinary. So what we're seeing is that with prostate cancer, the key to therapy is early detection. Early detection saves lives. Now, the argument that you're going to hear is that prostate cancer is an indolent disease, that it's not fatal, that people die with prostate cancer, not of prostate cancer. And I can tell you, as being in the trenches on this, that nothing is further from the truth. Prostate cancer today is the second leading cause of cancer death after lung cancer. Almost as many men will die of prostate cancer as women will die of breast cancer, and no one is saying that that is an indolent disease that doesn't require therapy. In point of fact, one man will die every 24 minutes. So during the course of this hour, 3 men in the United States will die specifically of prostate cancer. The real tragedy is virtually every one of them could have been prevented if the disease, as you can see, was caught early enough. Now, the problem with the USPSTF process is it doesn't consult with experts. No one with experience in the treatment of cancer is there. It develops recommendations in secrecy because it's exempt from FACA and the Administrative Procedure Act. It's the only government agency that's able to set payment policy that is exempt from these from this. And as I said, exempted from FACA and the APA, not required to hold meetings in public, not required to consider public comments, and not required to disclose its methodology. Since the USPSTF issued its grade D recommendation, one size fits all, which basically said that nobody should get screening, and it allows the secretary to deny coverage for screening, we've had a very significant effect. What we've seen is, as anticipated, a decrease in the screening rate from prostate cancer. But unfortunately, the men that are being, the decrease in screening is not the older man that would not benefit from it, but younger men that would benefit from screening. This slide, again, this will be provided to you, but this line right here shows a decrease in the incidence of prostate cancer, and most troublingly, and this is data from our group, which is the largest study that's been published on this, is that we can see a shift. The USPSTF wanted to decrease the diagnoses of low-grade cancers that didn't need treated. In fact, that incidence has stayed the same. What we're seeing is an increase in the number of people with very aggressive disease. Now, back when I was a resident, which was a long, long time ago, we used to see nearly a quarter of men present with disease that was metastatic and already spread. That has really gone down dramatically. But in the last few years, since the USPSTF recommendation, we're seeing increasing number of men present with disease that is already spread outside the prostate, and once the disease is outside the prostate, it is inevitably fatal. So we are seeing a shift to non-treatable disease. So we were worried about a public health disaster. We just didn't expect it to happen so soon. So there's also an economic impact. For those of you, you all have fiscal responsibility for the United States. If you diagnose a prostate cancer early and it's treatable, it's the cost of $9,000 to $30,000 per quality adjusted light year. Advanced prostate cancer costs $80,000 to $100,000 per quality adjusted light year. So not only is there the human tragedy of men that could have been saved dying, there's also an enormous economic burden for not taking care, doing this. Now, the big thing is that the recommendation was untimely. The use of surveillance was already increasing. 3 out of 4 men over age 75, and we were developing tools, molecular and diagnostic tools, to help us identify those patients that needed treated versus those patients that didn't need to be treated. So this couldn't have come at the worst time. The technology was being developed, and then the USPS pretty much stopped men from being diagnosed, which is really a tragedy. So just to sum up, the USPSTF Transparency Accountability Act requires a balanced representation of specialty providers. It requires public comment, and it requires consultation with relevant stakeholders. So this is a relatively minor tweak to what the USPSTF does. What it basically does, it says that right now, the only government agency that has the ability to make policy that affects payment is going to be subject to the same degree of oversight that every other agency that can affect payment. So in summary, PSA prostate cancer based screening dramatically improves survivability. There's been adverse trends since the grade D recommendation, and these trends will result in a major public health disaster, both in terms of the human and economic impact. The USPSTF Transparency Accountability Act is absolutely necessary to protect access to vital life-saving testing for men who may have prostate cancer. Thank you.
Great, thank you, Dr. Kapoor. Next, we have Dr. Serge Ginzburg. Dr. Ginzburg is a urologic oncologist specializing in laparoscopic and robotic surgery, focusing on genitourinary cancer care. He advocates for active surveillance and organ-sparing surgery whenever possible. Dr. Ginzburg is actively engaged in resident education, basic science, and clinical research. He has authored and co-authored many original research articles, book chapters, reviews, and instructional videos, and delivered numerous presentations at professional society meetings. Dr. Ginzburg?
Thank you very much for having me today. September is a Prostate Cancer Awareness Month, and I'm glad we're able to recognize the importance of this disease. I'm going to echo some of the data that Dr. Kapoor has mentioned, and I also want to emphasize the progress that healthcare and urology specifically has made in the field of prostate cancer, and underline the importance that healthcare policy has and what impact, positive or negative, it may have on our patients. So this is from the National Cancer Center, and I want you to focus on the maroon line. Maroon line is prostate cancer specific mortality, and you can see two arrows there. The first arrow represents widely accepted interval of PSA testing, prostate cancer screening, basically. And you can see that that line drops dramatically over the next 2 decades, signifying the fact that prostate cancer mortality has improved. Now, can all of this be attributed to prostate cancer PSA screening? No. But a lot of literature supports at least 50 to 75% of that improvement, of that progress attributable to PSA screening. So PSA screening is critical, and recommending against it is really irresponsible, in my opinion. This graph demonstrates prostate cancer that presents in advanced or metastatic stage, so patients that potentially could have been caught earlier and prevented from advancing into this stage. So you could see, again, similar time frame in the late 80s, early 90s with adoption of PSA screening. The prostate cancer presenting with metastatic disease is extremely high, and then the rate more than halves. So it decreases significantly after introduction of PSA screening. Again, supporting our efforts and our progress in managing prostate cancer. Can all this be undone with recommendation against PSA screening? Not all of it, but most of it. So it's really important to reintroduce PSA screening or make it available to all men. So what did U.S. Services Preventive Task Force recommendation do? It introduced a lot of confusion. So what you see here is different recommendations by various professional societies with respect to PSA screening or prostate cancer screening. And none of these, with exception of the U.S. Preventive Services Task Force, recommends against screening. Everybody has their own kind of spin on PSA screening, and they vary in age at which the PSA screening starts, the interval between PSA screenings, etc. And there's new and developing smart and targeted screening, which is extremely high yield and mitigates some of the problems that U.S. Preventive Task Force flagged with PSA screening. But again, none of the professional societies, with exception of U.S. Preventive Task Force, recommends against screening. So just recognize that. People that are really close to the data and on day-to-day managing patients with prostate cancer do not believe that PSA screening should be outlawed. So what impact U.S. Preventive Task Force has had on the screening? Dramatic impact. So how does prostate cancer screening take place? It takes place in your primary care setting. Your family doctor gets a PSA test, and if it's abnormal, then they refer you to a urologist. So, the primary care setting is really the gatekeeper for PSA screening. And who was impacted the most by U.S. Preventive Task Force? It's the primary care doctors. Okay, so they are easily influenced by this information, and you can see from this graph that PSA screening in the primary care setting more than halved from when the U.S. Preventive Task Force recommendation against screening was introduced. Urologists, on the other hand, while they were perturbed by PSA, by the recommendation, it did not impact them significantly. I think probably because we're closer to the data and we recognize the limitations of the recommendation. Harms of prostate cancer, these are the pillars on which U.S. Preventive Task Force based their recommendation, and really they can all be deconstructed. Risk of biopsy, yes, risk of biopsy is real, but with modern antibiotic prophylaxis and risk stratification so that not everybody gets prostate biopsy, I think we can mitigate that quite effectively. Overdiagnosis, I think we're a self-policing enterprise where we simply don't abuse this any longer. U.S. Preventive Task Force recommendation is based on practice patterns that are historic. The modern practice patterns, like Dr. Kapoor has mentioned, include active surveillance, and that active surveillance adoption approaches almost 50% of patients with low-grade, non-aggressive prostate cancer. So that's really addressed adequately. It's our job as physicians to reassure and educate our patients to relieve their anxieties, and I think we can address that in an effective way. Overtreatment, again, we talked about active surveillance already, and patient education and patient decision-making needs, they need to be engaged in how they're treated, and they should not be denied that choice. By not screening them, we're denying them the choice of treatment. And, this is an important footprint on our healthcare expenditures. $13 billion annually spent on prostate cancer care. So we really need to emphasize the importance of this situation. Thank you again for having me. I'll answer any questions later.
Thank you, Dr. Ginzburg. Next, we have Dr. Peter Knapp. Dr. Knapp is the co-founder and past president of Urology of Indiana, a 35-year physician urology and urogynecology specialty practice, serving 17 hospitals in central Indiana, and is the volunteer clinical associate professor of urology at Indiana University School of Medicine. Dr. Knapp is the co-founder and director of Strand Diagnostics, LLC, a forensic healthcare DNA lab in Indianapolis. In this role, he co-developed the no-error DNA specimen prevalence assay and kit used to eliminate medical errors due to specimen switches and contamination, improve diagnostic accuracy, and provide patient safety in the diagnosis of cancer. He was a founding board member and past president of LUGPA. Dr. Knapp.
Thank you, Anna. Is this on? Thanks, Anna. And we've just heard from our two previous presenters the importance, vital importance really, of diagnosing prostate cancer. I'd like to spend the next few minutes talking about the importance and the value of diagnosing it accurately. And see if we can get to my slides here. There we go. We're going to talk about DNA specimen provenance assay testing, which was just mentioned. We call it DSPA testing. And we want to talk about its ability to improve diagnostic accuracy as well as providing savings to the Medicare Trust Fund. Today, the promise of precision medicine and targeted therapies requires complete diagnostic accuracy and the elimination of diagnostic errors due to specimen switches and contaminations. And that's what we call specimen provenance complications. There's published clinical evidence that biopsy specimens are subject to occult misidentification errors. That error rate has been quoted as nearly 1% to as high as 3.5% in some laboratory settings. In a recent article in the Journal of Urology, it was pointed out that 2.5% of prostate biopsies are subject to specimen provenance complications, and nearly 1.3% of positive prostate cancer diagnoses are essentially wrong. The clinical problem is that biopsy specimens can have switching errors, which we call transpositions, or contaminations. And what that is where a pathologist is looking at two patients' biopsy specimen tissue under the same slide and doesn't know which one it is and has no idea that there are two specimens there, and allow errors to be made in the interpretation. And these errors can occur at any step in the diagnostic testing cycle. This slide looks at the no fewer than 18 steps in the diagnostic testing cycle, going from the office where the biopsy is obtained or the hospital surgical suite, all the way to the pathologist and his returning the report back to the treating physician to give the patient the diagnosis and treatment plan. But before all of that happens, there are at least 18 steps where there are multiple areas for human interaction where specimens can either be contaminated, switched, or mislabeled, resulting in a wrong diagnosis being delivered to the wrong patient. The clinical significance of this, Congressman Blackburn just walked in. Hello there, how are you? Can I ask you to come forward and say a few words? And I'll pause for a moment. Thank you.
Hello, and thank you all for being here.
That's the recording mic, that's the main mic.
There you go, multiple mics. How fancy we are today. Well, first of all, I want to say thank you to each of you for being here, for your interest in the subject, and for the work that you do to help raise awareness. We are so appreciative of this. Secondly, I want to say a thank you for the support that you have given as we have worked through our bill that Congressman Rush and I have dealing with the U.S. Preventive Service Task Forces and reconfiguring, requiring some accountability, some transparency, and making certain that people who are a specialist within an area are serving on those task forces. We know that as you look at the issues of prostate health, men's health, women's health, breast cancer, this and mammography, it is vitally important that we approach changing the composition and also some transparency and accountability through the rulemaking process. So I just say welcome and thank you so much for letting me pop in for a couple of minutes on what is turning out to be an incredibly busy and very short September. Thank you so much.
Thank you, Congresswoman. We had just seen the Candyland slide of how specimens go through the process and through many hands to get to the treating physician with a diagnosis. And the subject matter, the clinical significance of the issues of all the possibilities for human interaction and for mislabeling, for switching errors and contamination errors that can occur, these specimen provenance complication errors, is that the wrong patient can get the wrong diagnosis and be administered the wrong treatment. There's also substantial cost to these errors. In a recent report by Mullin, which is an independent actuarial firm, they reported this in April of this year, that they estimated that Medicare will incur $539 million in unnecessary treatment cost over the next 10 years, due to specimen provenance complications from prostate cancer patients alone. That's just prostate cancer. It's a significant cost to healthcare. The solution is DSPA testing, DNA specimen provenance assay testing. And what this involves is taking a simple reference sample from the patient at the time of a biopsy. It can be done with a buccal swab in the cheek, it can be done from a blood test, from a venipuncture, and this specimen is sent to the DNA laboratory where it is later matched with a tissue specimen from the histology specimen from the patient's tissue biopsy to confirm the identity and the diagnosis. It establishes specimen provenance, it establishes specimen purity, and it also provides diagnostic accuracy with DNA certainty. DNA provenance testing is widespread throughout the country. There are over 250 labs ordering DSPA testing regularly. 12 of the 15 largest urology practices use DSPA testing as the standard of care. And there are over a dozen patient and physician organizations that are demanding DSPA testing, including the American Urologic Association, LUGPA, Zero, Men's Health Network, and the Veterans Health Council. The problem is Medicare beneficiaries today are denied access to DSPA testing. CMS, unfortunately, has asserted it does not have the authority to pay for DSPA testing, and therefore the need for the current legislation that's been proposed. Prostate Cancer Misdiagnosis Elimination Act, which is sponsored by Congressman Bouchon and Congressman Payne, clarifies that D-spot testing is a covered benefit to protect Medicare beneficiaries and also to provide savings to the Medicare Trust Fund. So thank you very much for your attention today.
Thank you, Dr. Knapp. Lastly, we have Mr. Darrell Sabbs. For decades, Darrell Sabbs has served the communities of Southwest Georgia through hard work and determination driven by the shared belief that service is the rent we pay for living. Mr. Sabbs currently serves as Community Benefits Coordinator for Phoebe Putney Memorial Hospital in Albany, Georgia. His work with the hospital includes identifying ways to impact community health with particular focus on the underserved. He works closely with the hospital's Network of Trust, a national award-winning in-school interactive outreach program for pregnant teens and parenting teens in rural Southwest Georgia. He also serves on the Albany State University School of Social Work and is a consultant to the Morehouse School of Medicine and the Morehouse Research Institute. Mr. Sabbs.
Thank you. Morning. Good morning. First, I want to thank Congresswoman Blackburn for coming and seeing it, that it was so important for us to have this hearing. I'm not a doctor. I'm not a researcher. So I'm going to talk just good, plain old common sense around this issue, which I'm sure Bernie here will appreciate. Prostate cancer survivor. The population profiles are very clear. The evidence that we're hearing from our doctors is so amazing for me, one who's sort of in the weeds and boots on the ground on this issue. It's very clear. The new diagnostic opportunities. So we're talking about opportunities, guys. We're talking about not using a broad brush. Now, I'm not a conspiracy theorist, and I do believe that the panel had good intent, okay? But I do think that there needs to be a more broader view of the conclusions, therefore the recommendations. I know science is important, but I don't want to see a battle between science and the casualties be what I'm experiencing in communities. Because what we're experiencing in communities, you know, my view comes from families, it comes from neighborhoods, it comes from discussions in barbershops, it comes from visiting ICU units, it comes from going to survivor celebrations. You know, it comes from hearing daughters and mothers talk about, had my daddy not gone to that health fair to get their PSA, they would not be here. Now, it comes from going to funerals. You know, it comes from those kinds of experiences where the rubber really meets the road. You know, so a broad swipe or a broad brush at this does not consider the many variables and options. Okay, guys, ladies, you know that when it comes to health, women are a little bit more intelligent and educated. I'll just say that. Women are like the gatekeepers of health, right? When my children get sick, they go right by me to mama, and I go to mama. I mean, but when it comes to us and our male mentality, you know, how we respond to our own health concerns, sometimes it's got to be falling off or at its end result before we want to do anything about it. So given the lack of information, the misinformation, given the fact that we're mostly uninsured, we don't get a doctor. Ladies get a doctor much sooner than men do. So there's a whole men's mentality that's there as a hurdle. And then when you add into that confusion, the lack of options and opportunities. I hold a health fair in Southwest Georgia. I've been doing it for 15 years. As soon as these recommendations came in place, my attendance went from 400 to 200 right away. The health fair is the on-ramp for men who are uninsured, who in an area where there's no expansion of Medicaid, in an area where the scarcity and lack of providers are a reality. The health fair is an on-ramp for men. Men are concerned about their sex health, mostly more than their heart health, okay? So when you put those obstacles there, when you put those burdens in the way, then the casualties, you know, we're seeing a rise in Gleason rates. All of the doctors are saying that, right? And we know it has to be connected with the fact that men, when they do go, the doctors are saying such an aggressive migration has occurred. So we know that that's a surrogate for possibly higher death rates. Now, we don't have the science, it's not conclusive, we haven't studied this long enough, but we do know that we studied the problems, but we haven't really looked at the benefits. What are the benefits? I want to know if there's an opportunity for me to detect whether or not there's an element of cancer in me. Give me a screen. Women were smart. See, women are strong. Women are organized. They tried to do the same thing with mammograms. Women said no and pushed back. There's a very strong advocacy. Men lack that advocacy. You know, we lack that voice. And I think because and the funny thing about the policymakers are all men, mostly. So I don't understand why we're even having such a strong problem in understanding the importance of us being open, us allowing as much objectivity, and us allowing options, because one size does not fit all. Thank you.
All right, thank you, Mr. Sabbs. There is one more person I would like to recognize to have him say a few words. It is a gentleman that I met here a couple of years ago, Mr. Bernard Wooden. He is a DC resident, government employee, who is a prostate cancer survivor. So I wanted you all to hear from him his experience and his belief in screening and where he is now. Mr. Wooden.
Bernie.
Thank you. My name is Bernie Wooden, Library of Congress. Like the panel was saying, you have to have a good primary doctor. My doctor, every year he would do his annual check, and he noticed something. So then he referred me to a neurologist. Then from that point, I took a biopsy, then found out that I had several tumors. And what I did, I jumped on it right then. Let's get it out of the way. And I did the cyberknife, and then I did the radiation. At the present moment, I'm cancer-free. And you're gonna have your side effects, but you're living. You could deal with the side effects, but you got to keep praying, and you got to believe that you're gonna beat this. And it's just, I'm just, lost for words, because I'm still living. It's been a rough 3-4 years. I remember one day I'm at home and I walk past the mirror. I said, who is that guy? I mean, I was, so small, but I just prayed. You can't give up. You have to keep fighting and spread the word. Spread the word. Because I helped my nephew. I had told him, hey, get your PSA. He got it in time, and he went to the Baltimore Center John Hobson, and then my wife's cousin. I had to. I'm always telling people, guys, hey, get that PSA, regardless of how old you are, because you never know. Because see, I didn't have no symptoms. I did not have no. Everybody is different, and this is what you have to realize. What I went through, you may not go through. What someone else went through, they might not go through. And it's just something that you have to do. Thank you.
Thank you very much.
Thank you, Mr. Wooden. We have some time left for discussion, so I'd like to open the floor up for any questions to the speakers. I would ask you to speak loudly and clearly so that the entire room can hear you. Please identify whether the question is for a specific panelist or if it's for anyone to answer. So are there any questions currently? Yes.
Can I make a statement? I'm also a prostate cancer survivor, and my story is very similar to Bernard's, but it's kind of different.
Sure, yeah, come right up.
I'm Tony Goodman. I'm also a Library of Congress employee. My testimony and story is totally different from Bernard's. I had went to see my doctor because I was having shortness of breath as I walked up my stairs in my house. And so the nurse practitioner waited on me, and she was very thorough. She did a PSA test as well as other tests, and it came back showing particular results. My PSA had went from 1.9 to 2.8 in a year's time. So she recommended I go to a urologist, so I did. And when I went to the urologist, he said, well, I don't think you have cancer, but I'm very proactive, so I want to schedule a biopsy for you. So he did it about 2 or 3 months later, and the results showed that one tissue core was 85% malignant out of the 11 or 12 tissue samples that he took. So I went on active surveillance for about 2 or 3 years, basically just monitoring my PSA. And so about the 3rd year, other cores became malignant and stuff. So I decided to have my prostate taken out. And this has been about 2.5 years or so ago. So I'm totally cancer-free. And so I've been telling friends, everybody, males that I come in contact with, go to your doctor, get your PSA done, make sure. Because I've dealt with cancer personally, I'm cancer-free, but I've also had members of my family that have had prostate cancer, as well as other types of cancer. So it's a serious thing, and it shouldn't be taken lightly. And I'm speaking to the males, more so who don't want to go to doctors and have annual physicals and things of that nature. But my question for anybody on the panel is, I know now there's I think a thing now that's coming out dealing with proton therapy. So what is that all about in relation to treating people with prostate cancer?
So proton therapy is another form of external beam radiation. It uses a different type of particle, a proton, as opposed to some of the other particles that we use. And there's some notion that proton therapy may be a little bit more, that you can target it a little bit better. But the data regarding proton therapy is actually pretty controversial. There's really no evidence that proton therapy is of substantive advantage in terms of complication rate or survival compared to conventional forms of therapy. Really, the issue facing us is not how to treat prostate cancer, because we've got lots of treatment. You had surgery, you had CyberKnife, you had external beam, we have an expert on robotic surgery. Once we find the prostate cancer, we've got a lot of options. What's happening is that men are being denied the opportunity to know what's going on in their own bodies. Let's be completely blunt. What the USPSTF said is that a man does not have the right to know what's going on in their own body. That we say that if you get a PSA, as Dr. Ginzburg said, you may decide to get a biopsy. And if you get a biopsy, you may have cancer. And if you have cancer, you may opt for a cancer therapy that you didn't need, which is 4 decision points down, 3-4 decision points down the road. So because we don't trust you to make the best decision with your doctor for your own health care, we are going to take away the right for you to know what's happening in your body. And I know that this sounds Orwellian in nature, and hard to imagine. But this is literally what the circumstances are. And so what we're talking about doing is just simply giving, a PSA is just a piece of information that is used to discuss with your family, with a man's family and with his doctor, whether or not biopsy or other intervention is warranted. And that's really what this is about. These stories, we see it every single day, both of us, every single day. Men that would not be here without the PSA testing. Yeah.
Anyone else on the panel want to say anything on that?
I would just add to that I think that the USPSTF missed or ignored what our last speaker just discussed, and that is the role of active surveillance. Elevated PSA doesn't mean an operation or treatment. An elevated PSA, as Dr. Kapoor just mentioned, gets you to the next decision point. But even if a biopsy comes back positive for prostate cancer and is confirmed with D-spot testing, DNA testing that belongs to that patient still may enter an active surveillance program where a lower grade cancer, lower volume cancer will be observed to watch for its biological activity with repeat biopsies to determine whether or not that patient needs to move on to definitive therapy or not. And they completely, again, missed or ignored the standard of care, because what you described was exactly the standard of care. Thank you.
Just a few more comments, specifically on your question about proton therapy. So it's an analog of radiation therapy, and it's significantly more costly than traditional radiation therapy. There's only very few centers in the country that administer proton therapy. It only has short-term results and no significant proven benefits. So I second Dr. Kapoor's opinion on that. Another point I want to emphasize, hearing these two anecdotal stories about prostate cancer experiences, is that both of the members that spoke are members of the African American community, where prostate cancer is a lot more prevalent. It's 60% more common in the African American community and 2.5 times more lethal. And it's important to recognize that additionally, these men experience prostate cancer, are survivors, but their children are at risk. So we need to make sure that people at risk have the ability to screen themselves. Thank you.
Other questions? Yes.
Open question for the panel. Since we are in halls of Congress and prices gets brought up a lot, what's the cost of a PSA test?
Just to say that out loud for everybody to hear, someone just asked, what is the cost of the PSA test?
The cost of it really depends on the lab and the region, but typically I guess it would cost somewhere like $40 to $60. I guess is about the cost. But the issue is that $40 to $60 to somebody that is a earner and all that may not necessarily be a big deal. They pay out of pocket, and the thing, what was mentioned earlier, is that here in Congress, what was fascinating to me is that the USPSTF, which is a part of the administration, indirectly, of course, but issued a recommendation that no man should get PSA testing, and literally 1 week later, during his annual physical, President Obama got a PSA done. And so my view is, if it's good enough for the President of the United States, it's good enough for everybody else, because the risk is that if the Secretary acts to cut the benefit, and there are commissioners on MedPAC that are making that recommendation, that $60 for a person on a fixed income is a lot of money. And they won't get the testing. And we're seeing that it's just not being ordered on a routine basis by the primary care physicians. And that's really the tragedy. We heard two really uplifting, heartwarming stories. I'll tell you a converse. I had a gentleman that came in my office yesterday. He was an electrician. He lives in Massapequa, New York. Not going to win a Nobel Prize, okay? He's just a salt of the earth kind of guy. Came in, he was one of the guys that was a first responder in the electrical unit at Ground Zero, was exposed to a lot of toxins, has had 3 cancers since that time. His doctor stopped doing PSA testing in 2010. He presented with 10 cores of Gleason 10 disease that is metastatic in his entire body, And I just had this conversation. Yesterday was one of the worst days I've had. He's 53 years old. And he said to me, "Doc, you've been my doctor, my family's doctors for years. I have complete confidence in you. You're going to take care of me. You're going to cure this, right?" And I have to look that poor man in the eye and say, "No, I'm not going to cure this."
And in my case, you're talking about price, and I was talking about the health fair being an on-ramp. We provide for free. PSA screens. I mean, it's a part of the attraction to get men to come to the health fair. And once you're at the health fair, and most urologists say that, men would come in to check their prostate, and we'd find other issues, health issues in their life. But at the health screens, we were doing free screens, and really men were coming in the droves because they wanted to know, they wanted to find out. And largely this audience were uninsured or underinsured. And as a health system, we were providing it for free. But once the ruling came in, we could no longer offer it. And soon as the word got out that we were not doing it, then the attendance or the on-ramp for men to be able to take the snapshot of their health was no longer available. So the ruling has had major impact on men's ability to get in and men's interest in wanting to get in and the obstacles in the way.
I'm just curious, why couldn't you offer it anymore?
Because the ruling said that we could not do it. The recommendation said that offering, and I'm gonna let these guys.
Funding supplied by like a government organization?
Government organizations, right.
So in our case, we have, as part of our commitment to our communities, and we have 1.45 million active charts, which is about 10% of the entire New York metro area. He's one of our doctors. So we set up our own not-for-profit foundation, and we generate independent funding that largely comes from our own doctors. And we continue to do screening, and we continue to do PSAs.
Right.
Problem is nobody comes. They get the thing and say, well, okay, the government said, I don't want to get overly colorful, but there's more to a screening than just a blood test. And
Right.
if somebody can avoid certain aspects of the testing, they just don't want to come in. So we continue to offer it, but people just say they got an excuse not to come because, the government tells me I don't need this anymore. And so, and if anybody's interested, I don't want to get into the weeds on it, but it's astonishing how the USPSTF could have been so wrong in terms of their analysis of the data. It's stunning to position, as you saw, urologists don't react to it because our analysis of the data is completely different than theirs is, and it shouldn't be a fight among scientists.
But Dr. Kapoor, you said something very interesting. You said very bluntly that it just seems to say that we don't want you to know. And I, again, I'm not a conspiracy theorist, but I hear and I understand what you're saying. But I wonder and this is a tough question, what is being protected? Why would we not want you to know? Is it you're protecting from the abuse that could happen in the industry? What is it, in your opinion?
It's an interesting question, but I can't even speculate to it because we can't ask the USPSTF. They're exempt from the Sunshine Act. They're exempt from the Administrative Procedures Act. They're the only entity in the government that has the ability to set payment that are exempt. We don't have the right to ask how they came up with it. And that's why this bill really is just so important, to establish a level playing field, the same standard to an entity that has the ability to reach so profoundly into the lives of Americans, not just American men, because they make recommendations on all screening services, whether it be mammograms or colonoscopies or whatever else it is that they're making recommendations on. They have an unprecedented reach into the lives of people. And it's just simply granting the Americans the right to know.
Quick comment on the cost of PSA screening. I think the relative cost of PSA screening relative to the care that is required in the future is negligible. And there are mechanisms in place, grants. For example, we have a grant from the Foundation for Breast and Prostate Cancer to screen men in our urban community in Philadelphia. So we can get the test out there to the men. The issue is the Preventive Task Force recommendation discourages the physicians to order it. So it's not the financial barrier per se that is blocking PSA screening, it's the discouragement of the physicians to order it, and that's the bigger barrier.
Okay, we had a question here first.
Yeah, I'm Arnie Owens with Senator Bitter. We went through all this last year with breast cancer screening. And the task force issued its draft recommendations and their final recommendations earlier this year. Where are we in the actual process of releasing a final recommendation from the task force? I mean, your paper here says it's going to be released next year, so presumably there's going to be a draft recommendation in the end of this year. They've got the research plan now, we provided input to that. Where are we in all of that?
Well, we don't know. Again, they don't tell us a lot of this stuff. So what happened, I think, and I'll be a little colloquial here, that I think somebody in the USPSTF, with the way the trends are really, kind of realized that somebody may have screwed the pooch a bit on this one. Because for them to re-ask for a research plan so soon after issuing a final recommendation is really pretty unusual. So what, based on the overwhelming negative feedback and some of the adverse trends that we've seen, they've asked for a research plan to be put forward to reevaluate the question of screening. When that's going to happen, we can't say. But again, we're going to have the same issue as we had before, because once they're still not including specialists in terms of the decision-making process. They're still not transparent in terms of how they're evaluating the data. So unless we change the process, we may wind up exactly the same way. And in the interim, whether it takes them 1 year, 2 years, or 3 years, what is the human cost between now and then? Because one component of this is that of this bill is that the secretary cannot deny payment policy based on the grade D recommendation, at least in terms of PSA screening. That's something that we need to have now, not 2 or 3 years from now when they revise the recommendation.
In the back, please.
So I'm 23. Well, at that age when most men think that they're still invincible, and it usually takes a wake-up call, like what happened. My sister's 27. She's diagnosed with breast cancer this past March, and they found through testing that she had a mutation in the BRCA1 gene. And for me, that was kind of a wake-up call to start getting tested for things. But what age would you recommend that men start getting a PSA testing?
Well, there's as many different recommendations as Dr. Ginzburg said. Everybody recommends PSA screening except for the USPSTF, which the only thing I would say is they're not even a medical, you said medical society, they're not even a medical society. So everybody that's actually taking care of patients recommends screening. What the amalgam recommendation, and there was a consensus guideline that came out of a group in Australia, is based on what we know now about PSA trends. Depending on your relative risk factor, you get a baseline PSA, unless you have some unusual risk. You get a baseline PSA sometime in your 40s. And based on that baseline, you can determine what your follow-up is. We know that if your baseline PSA in your 40s is very, very low, your lifetime risk of developing prostate cancer is reasonably nominal. So if you have a PSA, it comes back at 0.2, maybe you don't need to get another one for 10 years. But if you have one that's a little bit higher, or if you're in a risk population, one of our veterans that's been exposed to Agent Orange or Ground Zero, African American men, people with a family history, then perhaps you set up a customized screening thing. Right now, it's not one size fits all, like USPSTF said. You get a baseline, you talk to your doctor, based on your own baseline score and your own risk factors, you should have a screening regimen that's customized for you. Your risk with the family history, with your genetic, with the genetic abnormality that's there, is going to be decidedly distant from my risk or Serge's risk or anybody else's risk in the room. So it's important to have a customized regimen, but the thing is to have access to that testing.
Excellent, fully agree. In your specific case, you have BRCA1 mutation, as you know, both BRCA1 and BRCA2 mutations in first-degree relatives confer a significant risk of increased prostate cancer, specifically BRCA2 high-risk prostate cancer. So absolutely, you should get screened earlier than an average man. So at least around the age of 40.
We have time for one more question.
There was I think this gentleman had
I believe it was asked and
Okay.
answered.
Okay. Anybody else? Saw one over here.
But I do have one quick question. You talk a bit about the transparency and how the ruling is a bit of a head scratcher. Is there any legal standard, at least, that the PSTF puts out in terms of, because it sounds like you don't know what the decisional factors are, how they're weighted. Is that an accurate?
Yeah, to a point. So, basically the problem, there's no urologist that believes that the screening recommendation should have been an A or a B, because the data on screening is very confused and there isn't any study that's really good. We've got a lot of epidemiological data that's pretty vague. What seems to have happened is that the USPSTF weighted a study called the PLCO study, as opposed to another study called the ERS. I don't want to get into the study alphabet soup that was there, but there are two big studies that directly contradict each other. The problem with and they're both flawed. So most urologists believe that since both studies were flawed and it was contradictory, we should get a C recommendation, which is we just don't know yet. It needs further study. But what the PLCO to give you an idea, and I asked this question, I'm going to ask it to the room, okay? So if you were going to design a study to evaluate PSA screening, the effect of a screening test, you would say, on one hand, I would screen patients, and the other hand, I set out, you wouldn't screen people. But the PLCO study didn't do that. The PLCO study said, we're going to compare screening against something called usual therapy. Because in the United States, PSA testing was fairly ubiquitous. And so what it turns out, that in the original publication, which the USPSTF hinged its recommendation on, you had one group of patients that got screened, and another group of patients that got screened 55% of the time. So you compared screening against 55% screening. And go figure, you didn't see that much of a difference compared to the European study, which was very dramatic. What we just recently found out, just in June of this year, and we can supply that literature, is that the data contamination in the control group in PLCO wasn't 55%, it was 90%. So the USPSTF hinged it, and we don't know how they weighted it, because they don't tell you, they just say that we looked at these studies. They based this decision that's affecting the lives of tens of thousands of men on a study that compared screening against 90% screening. Which is why, when Serge and I look at the data, we don't come to the same conclusion as people that never treat prostate cancer, because we say, this just doesn't make any sense. You can't make a decision on this. Which is why you need to have experts on the field, people that take care of cancer, people that are involved in the disease, helping the epidemiologists understand the numbers that they're looking at.
Yep, fully agree. Additionally, they looked at the benefits of screening and they balanced them against the harms of treatment. Well, the harms of treatment comparison is historic, right? Because they consider patients that would have basically non-aggressive, nuisance type rather than a risk type prostate cancer, and those patients undergoing aggressive treatment. That's hardly ever done anymore. Over 50% of patients with low-risk prostate cancer are no longer treated aggressively. They're on approach that this man has undergone, which is active surveillance, where you simply closely monitor the disease. So you are improving your screening with these new technologies, multiparametric MRI, genomics, proteomics. You're improving your screening value, and you're decreasing the morbidity of the treatment. So both things are working in favor of offering screening, whereas they kind of took the worst view of the screening and amplified the morbidity of the treatment, which is no longer applicable in the modern treatment of prostate cancer.
Any final words from Dr. Knapp or Mr. Sabbs?
The only thing I would add is that also looking at the different studies that have been referenced, the prostate cancer, there are a significant percentage of prostate cancers that are slow growing. They take a time to develop and affect the patient's life and health. And the initial studies that were looked at were younger studies. They're looking at 7 and 8 years of data. Studies that were the European studies looking a little longer at 10, 12, 14 years of follow-up. You start to really see the benefit of PSA screening. So that data hopefully would be looked at more accurately. Previously, again, was either missed or ignored. There was a significant difference.
All right, great. If we can give a round of applause to our panelists, please. Thank you all for joining us. Also want to thank our partners from the Foundation of Breast and Prostate Health, and also our friends who are present today from Zero, the American Urological Association, and LUGPA, who share in our concern about identifying prostate cancer and providing appropriate treatments if needed. So
can I thank Men's Health Network for their undying commitment to this issue. And it's because of that kind of advocacy that we're able to even have this discussion. So thank you so much.
Thank you, Darrell. Once again, we want to thank our congressional sponsors from the Men's Health Caucus, Congressman Markwayne Mullin and Congressman Payne Jr. and their offices. And thank you all in the audience for coming and sharing in this topic and asking your questions and participating. Have a wonderful day.